Good evening. Hi, welcome to CornerStones Health, Best of UEGW and ACG 2023. My name is James Lindsay. I'm at Barts Health in London, and I'm joined here tonight, as usual, by Peter Irving from Guy's St Thomas's. So it's an absolute pleasure to be with you here, sharing some of the best IBD abstracts from UEG and ACG. And for those of you that have joined some of our programs before, just to highlight that for the UEG ACG session, we really focus on clinical trials. So that's all we're going to be discussing today, the updates of some of the new clinical trials, both of established and new agents. And as ever, during the webinar, we'll be discussing between ourselves what we make of the data. Very important to say that the topics that we're covering and the abstracts that we've selected are based upon ourselves and really not related in any way to our sponsors or to CornerStones Health. And obviously some of the drugs we're discussing aren't licensed, and we will be reviewing off-label information. These kind of meetings only occur with sponsorship, and we're really grateful to our sponsors for this year's program. That's Bristol Myers Squibb, Celtron Healthcare, Lilly UK and Takeda, and as mentioned, obviously they have no input. Obviously it's a smaller program than our Best of DDW program, and it's put together by the course directors, Marla Dubinsky from New York and David Rubin from Chicago, alongside Peter and myself, and we select the abstracts, create the slides, and with some very gratefully received help from the CornerStones office, they're formatted for this presentation. So we're going to crack on if that's okay. And first slide really is just to remind us what a wealth of new agents and established agents that we're going to be talking about. We have obviously the anti-integrins, P40, P19s coming online now, lots of slides about that. Some about the anti-TNF, particularly the new subcutaneous versions, and some quite interesting trials of infliximab and adalimumab from the recent past. There are some new agents, the JAK inhibitors and the other small molecules, the S1P receptor modulators. And so we'll be going through data from many of these. And I'm going to start with an old friend, vedolizumab. And I think this is a really interesting area of research. We are obviously keen when we have more and more therapies available for us to understand which is the right drug, which is the best drug to use in any particular situation. Obviously, the ideal way of finding that out is a head-to-head trial. Obviously, we have a head-to-head trial of vedolizumab versus adalimumab in UC, and we also have head-to-head trials in Crohn's disease, which we're going to come on to a little bit later. But of course, you can't have a head-to-head trial for every situation, and so in those situations, you often use cohort studies, and you accept the fact that the patients in each cohort may be different, but you then try and adjust for that, either using propensity scoring or inverse probability weight matching, in order to account for the impact on differences in baseline factors on subsequent results. And that's what the EVOLVE expansion study did. It took a group of patients who were naive to biological therapy with complex Crohn's disease, in that they had to either have perianal fistulizing disease, severe disease, or let me just get the definition up here. And with that, I think it's on the next slide, actually. Okay. The definition. They then looked at those who were treated with either vedolizumab or ustekinumab, active Crohn's disease was an active fistula, prior Crohn's disease-related surgery, or Crohn's disease-related hospitalization within 12 months prior to treatment initiation. So these were patients with relatively active degree disease. It recruited across European countries and Australia, and nearly 600 patients in total were included. As I said, they were then matched, and the outcomes were compared. And what you can see is in a bio-naive population, it didn't seem to matter whether you used vedolizumab or ustekinumab from the perspective on the left of clinical remission over 36 months, or clinical response on the left and clinical remission on the right. Now, the definitions of response and remission in this sort of real world data set weren't as tight as the definitions that we would see in normal clinical practice. It was a sort of stepwise approach. If they had a Crohn's disease activity index, they used that. If they had a Harvey-Bradshaw, they used that. And if they had neither, then they looked for wording within a clinic letter suggesting response or remission. So certainly not as tight as you might see in a clinical trial. But then if we move on to mucosal healing, again, this was in the subset of patients who had endoscopy after treatment, and that was a smaller subset of patients, but also treatment persistence. Again, you really see no difference, and that's the whole message of this trial. And here we are looking at adverse events. So the message of this Evolve expansion study, large cohorts, but obviously there will be differences in the patients treated bio-naive with vedolizumab and bio-naive with ustekinumab, but that was attempted to be matched with this weighted response assessment. So I guess that perhaps might be what we expect, actually, Pete. There's not much difference between using first-line vedolizumab or first-line ustekinumab. I think if we go back, I think what we saw from the LOVE-CD trial from Amsterdam was that the early use of vedolizumab in Crohn's disease, particularly as a first-line agent, was particularly effective at causing mucosal healing, perhaps more effective than we thought it would be.
I mean, I think, the message that always comes out with Crohn's disease is that the earlier you treat it, the better the response. And we're in this really difficult situation now. Actually, not so much in first line, because in the UK, let's face it, we tend to use anti-TNF first line because it is so much cheaper. But in that first switch cohort, where we're trying to decide between different drugs, now we'll talk about some very good evidence in relation to how we make that decision between two drugs. But all these other drugs, it's very tricky. And the other thing that I find very difficult is if we think about using anti-TNF first line, what we don't know is if that influences the response to subsequent drugs.
Absolutely. Well, I mean, we know some things from that. For example, the LOVE-CD trial would tell us that if we use anti-TNF first line, the mucosal healing rate with vedolizumab is much lower in patients who've previously been through anti-TNF, and we see that in all the phase 3 pivotal trials. So I would imagine that the benefit of but of course, whether that's the same for all the second line drugs you use, we're not sure.
Exactly, and it might. So let's just flip it around and say, well, if we had a trial where you used vedolizumab first line and then infliximab second line, would you see an equally, impressive decrease in response?
Yeah, I mean, there is actually data looking at that. The Canadians, Brian Bresler, looked at that as this was not part of this study, it was a separate Evolve study.
But it was Evolve, yeah.
It was called Evolve, but it was a separate cohort of patients.
Right.
And he showed that although there was a drop-off of benefit if you use vedolizumab second line compared to vedolizumab first line, there was no drop-off in benefit if you used infliximab second line after vedolizumab compared to infliximab first line. Although, to be fair, the absolute numbers in that trial were tiny, and so I think that's hugely open to bias. But I think the point you made first is that the message that should come out of this, which is that the earlier you use an effective treatment, the better the outcome will be. And of course, at ECHO next year, we'll see the results of the Profile trial, that big UK trial, which randomized people really early to receiving top-down therapy versus step-up therapy right at diagnosis, and it will be really interesting to see those results.
But sequencing, I think, is going to be such an important question as we move forward, and what the effect of one drug has on others in the future. But anyway, at the moment, I quite agree that the message to take away remains early treatment is the most effective treatment.
There's a question there from, would be helpful to know more about the methodology that was used. It would, Paul, and unfortunately, I don't have exact details, nor do I have from the abstract details of what factors were matched against. And I think that's almost essential. Without knowing that, it's really very difficult to know whether enough appropriate things were matched. And of course, that I completely agree. It was inverse probability treatment weighting is all it says, but I completely agree. To balance demographic and clinical characteristics, without knowing it, it's really difficult to know.
And I love that point that you make there, Paul, because that's exactly what I was about to say, is that people say, we have done propensity score matching, we have done inverse probability of treatment weighting, and we just say, oh, okay. And of course, there's particularly with abstracts, there is no quality control of that. And I think it's also true that when papers are reviewed, unless they're reviewed by people who truly understand the methodology, then I think there are some questions to be asked there.
Absolutely, you need to know what's matched and what's not matched to get an idea as to whether it's a fair comparison. Let's move on.
Okay, so on to ustekinumab, which of course we've had available now for a little while. We're going to look at a couple of things here. We're going to look at the POWER study in terms of clinical outcomes, and then we're going to look at some PK from the POWER study. So just to bring the POWER study into perspective, this is basically looking at patients who have had secondary loss of response to ustekinumab, and instead, and they're already on 8 weekly, which is of course the maximum licensed dose for ustekinumab, and instead of dose escalating by going to 4 weekly, and that was looked at a little bit in, I've forgotten the name of the study, Stardust. Didn't show a great benefit, I think it's fair to say. It was looked at in Stardust, and of course I think many of us in the UK find this difficult to do. However, what some of us have done is tried giving a rescue intravenous dose, and that's exactly what was done here. So patients who were losing response on 8 weekly ustekinumab were randomised in a blinded fashion either to a placebo intravenous infusion as per induction, so banded at about 6 milligrams per kilogram, or carrying on subcutaneous. So just one of those injections basically was replaced by a booster infusion, and then outcome was at week 16 was the primary endpoint, which is based on clinical disease activity in terms of CDAI.
So the difference between the two groups is you either just carried on with your 90 milligram sub-Q, or you had one IV dose and then only one sub-Q dose, effectively, by the time you analysed it at week 16.
Yes, exactly right. Yeah. So, and just replacing one of those subcut doses in that outcome at week 16. So here are the slightly messy results, and the primary endpoint is outlined on the left there. That is a clinical response, and you can see in all patients there, orange is the booster dose, blue is the continue on subcutaneous maintenance dose, and you can see that the delta there is about 13%, 12%, and this was not statistically significant. There was then a sub-analysis, both in the patients both at clinical response and on the right at clinical remission, subdividing the patients by how many biologics they had previously received. So we can see along the bottom there, no prior, 1 prior, 2 prior, 3 or more prior. And at least in terms of clinical response, there appeared to be numerical differences for the no prior, 1 prior and 2 prior biologics, less so for the 3 prior. I think these are probably unpowered endpoints, so those p-values are probably nominal, but you can see nominally for 1 prior biologic, at least there was a statistical difference. And then if you go over to the right-hand side of the screen and you look at clinical remission, again, you'll see there is a delta in all patients, but it's only 6%. And then if you look at the no prior biologics, 1 prior biologic, and 2 prior biologics, again, some numerical differences there, which we lose with 3 prior biologics. And then we can also see some endoscopic data at week 16 here, which is even more confused, I think it's fair to say. For all patients here, there was an endoscopic difference. For the patients with no previous biologics, no difference. And then you can see if you're going along to the more biologic exposed patients, some numerical differences there, again, only one of which is significantly different. Let me just show you the PK data before we talk about this. That graph on the left there is what happens to serum ustekinumab concentrations over time. So you can see at time point 0 on the x-axis, both the subcutaneous arm and the intravenous reinduction arm are coincident, which of course is what you would expect. There's then a post-dose level, and you can see that the concentration of ustekinumab shoots right up.
And that's a logarithmic scale.
It is indeed. You can see it shoots up from about 1 to about 100. Which again, you would certainly hope would be the case. And then it comes down over time. So at week 8, you've still got some benefit, at a higher concentration. And then at week 16, there is still a little bit, about twice as much ustekinumab hanging around at week 16. If you look over on the right-hand side at the different tertiles, basically, of ustekinumab concentrations, there are some minor differences there, but I don't think anything really stands out here. They say in the abstract there are differences there, but to me, there's no striking differences to see.
I don't see a big exposure response curve there, and also, I mean, there is quite a chunky increase in drug level. It makes you wonder whether the data or the practice of escalating to 4 weekly is really worthwhile. Certainly now that there are alternatives, it may not be worthwhile. But I mean, that both Stardust was a negative trial. This effectively is a negative trial. We've shown you've got a really nice peak in levels, and it doesn't seem to have a clinical benefit. So, not sure that 4 weekly is a long-term strategy, and it's also one of the most expensive strategies you can use.
Right. What they were missing here was the third arm, wasn't it? Which was reinduction and then Q4.
Yeah.
And there is real-world data out there that says that those people do a bit better. But I think, again, in terms of UK practice, this is actually quite a useful study because we could do this. You could kind of get away with this, whereas most of us can't get away. We're going to Q4. There's a few people out there. I think Seb in Hull had been doing it a lot. I'm not so sure if he's able to nowadays, but we certainly can't do this to any great extent. So in terms of UK practice, I think it says this is not a brilliant way forward, and I think we accept that Q4 is not great. So back to there's a question here. Now, how can I do it? Have there been head-to-head studies between infliximab and vedolizumab or ustekinumab? No.
Is a simple answer to that.
No. At least not in terms of proper head-to-head studies. There have been analyses looking at that, but they're not head-to-head studies.
No. So I'm going to move on to a head-to-head study, and this is the sequence trial. This was probably, I think, the most interesting data that was presented at UEGW, and I think will change UK practice. Risankizumab for Crohn's disease is now licensed and NICE approved. And this was looking to see whether in a cohort of patients with Crohn's disease who had active disease with the standard criteria, who had previously failed at least one anti-TNF. They could have failed more than one anti-TNF, but they had to have failed at least one anti-TNF, but they could not have received vedolizumab or ustekinumab or a JAK inhibitor. So these were pure anti-TNF failing patients, which actually neatly mirrors with the NICE approval for risankizumab, which is after an anti-TNF. And it was then taking those patients and randomizing them to either receive risankizumab, which is given IV 600 milligrams at weeks 0, 4, and 8, followed by a subcutaneous dose at week 12, and then every 8 weeks after that, and that's a 360 milligram dose, compared to standard dosing ustekinumab, which is the 6 milligram per kilogram dose banded IV infusion, followed by 90 milligram 8 weekly, and patients continued on this for a year, and that was the first part of the sequence study. There was a mandatory steroid taper at week 2, and importantly, neither the investigator nor the patients were blinded to the treatment. Everyone knew what they were getting, although the assessments were blinded because the endoscopy assessment was centrally read by readers blinded to drug and time, and the Crohn's disease activity index was calculated blinded to treatment. So this is an efficacy blinded but open label, otherwise randomized controlled trial. There were two primary endpoints. The first primary endpoint was looking for non-inferiority of risankizumab compared to ustekinumab in 50% of the population recruited. And the reason I suspect they did this was to look for futility, because if the trial was not going to show benefit, there was no point continuing with it. But as you can see here, not only did it met non-inferiority, because the bottom line of the lowest part of the 95% confidence intervals is well above, well to the right of the minus 10% that they set as their non-inferiority margin. In fact, actually, it shows superiority at week 24. And then if we go to the second primary endpoint, which was endoscopic remission at week 48. And I think endoscopic remission, yes, was an SES-CD of less than or equal to 4 with at least a 2-point reduction. So quite a nice, tough definition of endoscopic remission. You can see a clear superiority of risankizumab over ustekinumab with a delta of 15%, a delta of 18% for clinical remission. And then if we look across the rest of the secondary endpoints, using endoscopic response at week 24, steroid-free data. The data is clearly significant and superior for risankizumab compared to ustekinumab at all time points. Quite a convincing trial.
Yeah, and it's a very it's a great trial, isn't it? What criticisms can one come up with? Well, one thing that has been asked is, well, is this a dose-related thing? Is ustekinumab somehow underdosed? But I kind of think we've just answered that.
We've just answered that.
Right.
The ustekinumab doesn't appear to be underdosed.
No.
Given the extra IV didn't show that. And I guess, obviously the question then comes, what's the impact of the fact that it wasn't blinded, that patients weren't blinded or investigators weren't blinded? They were offered either standard ustekinumab or shiny new risankizumab. And I think that is a potential weakness. I think certainly for the clinical endpoints, probably not for the endoscopic endpoints. It's difficult to know how that would make an endoscopic difference. And I think the other thing to say, of course, is that it wasn't that people could drop out of the ustekinumab arm and then receive risankizumab, because risankizumab wasn't available outside of the trial during the course of this trial. And although more people in ustekinumab did drop out than dropped out from risankizumab, I think it was about 30% of the ustekinumab group compared to about 10% of the risankizumab group during the year of the trial. They dropped out because they had active disease, and that's often the case. The inferior drug has more dropouts during the clinical trial. So, I think it answers a very clear question, which is which drug should you use in a patient with active Crohn's disease despite an anti-TNF? Well, we now have a trial to answer that.
We do, and at least for the moment, cost-wise, not much to choose between them.
No, when ustekinumab goes biosimilar at the end of next year, that will raise a problem.
That's going to create some interesting questions. So before we move on, this is not entirely surprising, because we have seen in other diseases such as psoriasis a difference. One final thing then, James. If you look at steroid-free endoscopic remission at week 48, so there you go. It's sort of set of bars number 4 along from the middle
patients
there. Right. It's still only a third. Here we are celebrating the fact we've got this great drug. Ustekinumab is not a bad drug. Okay, if you look at it in C-view, it's the same as adalimumab.
Yep. Different population, obviously.
A very different population, TNF-L, but I'm just sort of trying to anchor it to other drugs, if you like. If we go back to an abstract a little while ago that we've just presented, similar to vedolizumab, again, and so we've got this apparent improvement in outcomes of risankizumab, and yet endoscopic remission still only in 30% of patients.
I guess one of the things I would always say to that is you need to know where the patients came from. An SES-CD score of less than or equal to 4 is effectively a couple of aphthoid ulcers in 2 different segments. Would mean you'd fail that. If you had an aphthoid ulcer in 2 different segments, you would fail that. And if you started with rip-roaring deep ulceration and you got to that, I wouldn't call that a treatment failure. So one has to be a little bit careful. You need to know where a patient started for before you interpret where they've come to, and also you need to know that some of these endoscopic scores are really quite tight. I think there's one other really important part of this trial that we haven't seen yet, is that the patients who were on risankizumab continued on drug in the trial for a further year. So we'll get an idea of what the impact of treatment is over 2 years on some really interesting endpoints like hospitalization and surgery, because I think the cost argument might be, as ustekinumab becomes treatable, if you can show that risankizumab actually reduces the rate of surgery and hospitalization, that might change the balance slightly.
And so we have a very reasonable question here that sort of asks that question. Where do you think when Usti becomes biosimilar, and who knows what cost it will be, but at some point it's going to be significantly cheaper. Once it's a lot cheaper, what is the right place for risankizumab then?
It's really difficult, and I think it is things like the hospitalization and surgery data that will be important. I mean, we know from Fortify that patients who have previously, which was the phase 3 maintenance trial of risankizumab placebo-controlled in Crohn's disease, we know that patients who previously received ustekinumab did respond to risankizumab, but it was a small numbers. We don't get a feeling for whether you can use risankizumab after ustekinumab and still get the same benefits that you see in the sequence trial. So I think it will be things like that hospitalization data that's really important.
And I'll quickly follow up with that. Of course, also we know from the early access scheme that AbbVie put together.
Yes, you've done data on that, haven't you?
Yeah, I mean, we put about 30 odd patients into that, and remember, all those patients had to have failed TNF, Vedo, and ustekinumab.
Yes.
And of course, we and others had pretty good responses there. But again, it takes us back to sequencing, doesn't it? Does giving ustekinumab first, other than delaying, other than a time effect, does somehow giving ustekinumab first make the response to risankizumab worse?
I think, well, obviously we don't know the answer to that. I think one big thing is time. You can't prevent a complication that's already occurred.
Yeah.
Great question there about side effects. Was the dropout to ustekinumab related to side effects? Was risankizumab better tolerated? No. There were no differences effectively in the side effect profiles within the 48 weeks of the study between the 2 drugs, and the vast majority of the increased number of dropouts with ustekinumab was due to disease flare. So we're going to move on to another risankizumab. This is the risankizumab in ulcerative colitis trial. We're going to look at the induction trial. It's a standard phase 3 randomized responders trial, but we're only looking at the induction. And somewhat confusingly, the dose of risankizumab for ulcerative colitis is 1,200 milligrams, twice the dose that you see in Crohn's disease, given 3 occasions, and then you would start the sub-Q, which in this trial was 180 or 360 over the subsequent year. But we're just going to show you the induction data, 2-to-1 risankizumab versus placebo, and a standard set of inclusion criteria: significantly active disease, endoscopic subscore of at least 2 or 3, and biopsy confirmed diagnosis. And you could have been on either a biologic or non-biologic treatment, but you could not have previously had ustekinumab. And I can't, yes, you could have had JAK inhibitors and S1P blockers. And what we're going to see here is the overall population on the left, and this is clinical remission at week 12. And you can see there is a significant delta, 14 points above placebo. Perhaps not hugely impressive compared to some of the other data we've seen, but there is a data. And really interestingly, to me anyhow, is that what you see with risankizumab is that there is a drop-off in that benefit in patients who've previously received a biologic therapy. And the reason I think that's interesting, and I'm not sure we're going to come on to the data, is that when you look at mirikizumab in ulcerative colitis, which is another P19, also an IgG1 antibody, you don't see that drop-off. You see it is just as effective in bio-exposed as bio-naive, and I don't know the reason for that. Endoscopic improvement, endoscopic remission, you can see here in histological remission. So yeah, risankizumab works. in ulcerative colitis, admittedly at a higher dose than used in Crohn's disease. Interesting to that comparison between mirikizumab and I can't really explain it.
No, I mean it could just be exactly. It could be numbers. It might not. It might not be real. I'm just going to come back to a question here. So Paul asking, are there any studies, open or complete, where treatment decisions depend on endoscopic outcome? Do we know targeting endoscopic remission is helpful? Well, there's the UC study, isn't there? Which is, I can't remember what it's called.
Verdict.
Yeah. Is that what it's called? That's vedolizumab,
yes.
And it's driven by what's happening endoscopically, and indeed right the way down to histology as well, isn't it?
Yeah, it's a 3-arm trial.
Yeah.
Patients all receive vedolizumab, and then they're assessed endoscopically at various time points, and patients are either escalate based upon clinical symptoms, on the presence or absence of endoscopic disease activity, right, or the presence or absence of
histology.
So that trial's ongoing. Yes, to
yeah.
that. And of course, in Crohn's disease, there's REACT-2 and Stardust. Both of those had treatment decisions mandated about endoscopy. Stardust, it was escalation of ustekinumab, and in REACT-2, it was driving through adalimumab, standard dose weekly, add in a combo therapy. And in both of those, they were both negative studies. But there are complexities to these kind of trials, because how do you define endoscopic healing for Crohn's disease? I think there is complexity here. And
I think the other problem, of course, is particularly in Crohn's, doing an endoscopy-driven study is very difficult. Yeah. There are certainly studies out there that are going to use ultrasound, which is probably a reasonable surrogate, I think.
Yeah, and also, so much easier to recruit for an ultrasound study.
Right,
and Verdict was much easier to recruit to because it used flexible sigmoidoscopy for disease assessment rather than colonoscopy.
Yeah, okay. Just you keep an eye on those, because there's a couple of other questions coming in. I'll just whiz over to mirikizumab, which James has just mentioned. So we'll look at a few things here. We've seen the results of the induction study, Lucent 1, the maintenance study, Lucent 2. They're now published in the New England Journal. And we saw some open label extension data. That's Lucent 3. So these are the patients who come out of Lucent 2 in response and then go on to open label for weekly subcutaneous mirikizumab, which is now available, actually. It's 2 injections of 100 milligrams, slightly tediously, but otherwise it's out there and we can start prescribing it. So here are the open label data, and it shows us at the top left clinical response at week 104, split by those patients who are in response at week 52 and in remission at week 52. It then shows us on the right clinical remission at week 104, corticosteroid-free remission at week 104, and endoscopic remission at week 104. And the 3 different shades are basically different ways of looking at response in open label extension studies. So the harshest way of doing this is non-responder imputation. So in other words, that assumes that anyone who is no longer being followed up is a non-responder, and at the other end of the spectrum are the as observed cases, which is basically just looking at response in those people who stay on treatment. And of course, the truth is probably somewhere in between the two. I think it's fair to say we see this pretty much with every drug. That overall, if you stay on the drug, you tend to do well. That if you are in remission at week 52, you tend to do a little bit better than if you're a responder at week 52, although not markedly better. But I think it's fair to say
this is a very selected population, because these are people who responded to induction and then responded or remitted during the maintenance arm. So these are good responders, aren't they?
Yeah, but that's reality as well. Okay, these are the patients actually because
they're going to be on the drug at the end of the year.
And that is always the criticism you get of these. But then and it's of course true. One mustn't think that 87.5% of people who start mirikizumab are going to have endoscopic remission at week 104. But I think that's not what these analyses. That's not how we should interpret these analyses. We should be thinking people who stay on the drug, how well do they do when they stay on the drug? Because that's important. It's a long-term gain, and I find it relatively reassuring to see that in a good proportion of patients you do have endoscopic remission, which will be a Mayo of 0 or 1 at 2 years after having started the drug. Then if we then go on to one of the other standard sub-analyses we see in many trials now, but again useful. This is looking at extended induction. So within the license for mirikizumab, you are allowed to give 3 additional intravenous induction doses, and we see that when you do that, you capture about another 50% of patients who didn't respond to initial induction. And then importantly, if you look beyond there out to week 52, actually those patients again are tending to do reasonably well. And I think what you can see here is that you kind of capture more in terms of remission, in terms of endoscopic remission, as you keep going with the drug over time.
I guess an important thing to know about this kind of data is what's the impact of prior biologic exposure on this data? Because obviously, the desire to continue a patient on a drug that hasn't delivered response by the end of week 12 is going to be quite driven by how many other choices they've got. And are you likely to want to continue? And so for me, it would be quite useful to know whether this was mainly driven by bio-naive patients or bio-exposed patients. And of course, we don't know that. I think.
No. And I think the other thing is that there's a little bit of a danger here that when you say non-responders at week 12, actually, I don't think these really are non-responders at week 12. They're non-responders in terms of a clinical trial definition of response.
So
they're not people necessarily who have had absolutely no response to drug at all. They might include those people because it's a placebo induction study, and so there may be people who said, okay, I'll carry on, and they might have had drug. But it's going to be a slightly, sometimes if you've got no response at all by week 12, you're just going to say, let's get out of this trial. And I think honestly, nowadays, unless you are at the last chance saloon, if you have given a drug for 3 months and you've had absolutely no response, if you've got I don't think you continue it either. Partial responders, I think I would, and I think you're right. Those patients who are biologic failed, and particularly, we should say advanced therapy failed, and particularly multiple advanced therapy failed, I think you're going to be prepared to give them longer to respond. And then the final MIRI study relates to bowel urgency. So many of you will know that Lilly included a validated measure of bowel urgency, the urgency numerical rating scale. Other trials do look at urgency, but not with a validated endpoint. And I think, I think the fact that this was looked at is good. I think it partly relates just to the fact that people who do better tend to have less urgency rather necessarily than being something related specifically to P19. But I think the most important thing to me is it enables us to concentrate on bowel urgency and to start thinking about it. And what this analysis looks at here is how important bowel urgency is in relation to quality of life. It's a slightly busy slide for which we apologise, but basically what it's looking at is, if you look at the bottom at the legend there, you'll see it says bowel urgency CMI, so that's a clinically meaningful improvement, and they've either got it or they haven't. That's the blue and the orange bars. And then bowel urgency remission, and they've either got it, the sort of light blue versus the black.
Are we going to call that teal? I'd call that teal. Anyhow.
Thanks, James. I think that's a really useful input. And then it's splitting them up by whether they're responders or remitters, and then it's looking overall at their IBD-Q response at week 52. I think what they're trying to say here, and I think it's right, is that whether you are in response or remission, your quality of life partly depends on whether you have bowel urgency or not. And I think that is a useful thing to think about.
Yeah, I mean, if you have bowel urgency, you are less likely to have an improved quality of life, is what we're hearing. Right,
exactly. And of course, it means that what we should be trying to do is to understand bowel urgency better and understand the reasons for not achieving bowel urgency remission, whatever that means.
Yeah,
okay.
I completely agree.
Good.
So we're now going to move on to the third of the P19 inhibitors. This is guselkumab, and this is going to make life complicated when all these drugs are on the market, because there will not be head-to-head trials comparing them all. But guselkumab, the only obvious distinction between it and either risankizumab or mirikizumab is it's an IgG4 antibody rather than an IgG1 antibody. But there are a series of abstracts, and I'll talk you through some of them. So first is the phase 3 ulcerative colitis, guselkumab versus placebo, and as with the others, you have an induction IV dosing every 4 weeks with the primary endpoint at week 12. This recruited, again, a very standard set of patients. When you look at the primary endpoint, clinical remission, don't forget that includes an endoscopic improvement, because to meet a Mayo clinical remission, you have to have reduced your Mayo score to at least 0 or 1. Clinical response, endoscopic improvement or normalization, which is defined as an endoscopic subscore of 0, histoendomucosal improvement. You can see again a significant benefit across a range of endpoints. I was looking at this just before I came on and comparing it to the risankizumab data I showed from the INSPIRE study a few slides back. It's pretty much almost identical, I would say, to that. So you know, it fits with that. And like with the risankizumab data, when you look across a variety of endpoints, we've got clinical remission, symptomatic remission, which is the Mayo score without including the endoscopic subset, or clinical response. You can see that the magnitude of benefit and the delta is higher in patients who are naive to advanced therapies compared to those who have previously responded. And for my mind, that does draw out a benefit from mirikizumab, which did not show that.
I'll let you finish guselkumab before we answer this question.
Yeah, no, I've just seen that question. Endoscopic endpoints. This is doing exactly the same thing with endoscopic endpoints, and the message is exactly the same, effectively. One of the things that we have seen coming out of quite a few trials recently has been about speed of onset. And I think that's important. I mean, obviously you may say, you know, working within 1 to 2 days compared to 1 week to 2 weeks may not be that important, but it is important as to whether you might feel the need to use concomitant corticosteroids. And if you have a drug that you think is going to work within the first few days and you can access that drug efficiently in your system, then I doubt, you know, you'll need to use concomitant steroids. For guselkumab, we have that data, but not from a day by day. We have it from a week by week. But you can see that from the perspective of response, you do start to see a statistically significant, but numerically superior benefit of drug as early as week 1. We don't have the day-by-day data, and you will remember for upadacitinib, we have the day-by-day data, and it comes out, you know, with benefits as early as day 1.
Yeah, I'm less sold on speed of onset. I think this is a long-term game.
Yeah.
You know, and clearly, I think actually the bigger impact is when you can start the drug. And this is where, you know, certainly for us at the moment, actually getting the intravenous infusion started is a big challenge. And that's where oral therapy is actually starting to look quite attractive.
Yes, because even if you use a home care company to deliver your oral therapy, you can prescribe often the induction dosing from your pharmacy, and therefore patients can start it that day. And you're absolutely right. We also have capacity infusion issues with a weight, so that a day here and a day there is probably not going to be the biggest factor. I'm probably going to skip through the next couple of slides because it's just looking at the histological improvements, and I have to say, at this moment in time, until we get data on what the benefit of modifying therapy based upon histology is, which we'll get from that verdict trial we talked about earlier, I'm not quite sure I know how to deal with this data, so I am not going to deal with that. Right, okay, the last set of gazelkamab abstracts are looking at the phase 2 Crohn's data. So we don't have a detailed report of mirikizumab in Crohn's disease. We've obviously shown you the risankizumab in Crohn's data. That was the phase 3 trials we showed last year, but this year we showed the sequence study. This is gazelkamab in Crohn's disease. Because it's a phase 2 trial, there's a bit of a dose ranging thing going on, and you can see here that you have 3 doses of gazelkamab induction, all given at 3 times at weeks 0, 4, and 8, and then treat through ongoing treatment with 1 of 2 doses of gazelkamab in maintenance for weekly, the 200 or 100. So don't forget, this is not a randomized responder, this is treat through. And really interesting, in the Galaxy studies, not only did you have a placebo arm, but you also had a non-powered ustekinumab comparator arm at standard dosing, 6 mg per kg IV versus, and then going on to 90 mg sub-Q. If you were a non-responder to placebo, for some reason that I can't quite work out, they give you ustekinumab rather than gazelkamab. But anyhow, so we've seen some of this data before, and this is the induction study. So this is the end measured at, I think it was measured at week 12, although it implies it was measured at week 8, but it was measured at week 12. This just shows the fact that there doesn't seem to be a huge dose response. You can see, in fact, actually the most effective dose seems to be the 200 milligram dose in terms of absolute change of Crohn's disease activity index. Here you can see all doses of drug are more effective than placebo, but gazelkamab doesn't seem to me to be having such a benefit clinically compared to ustekinumab. And then here is those data that we showed you for other things. These are the bio-exposed population, and this is the bio-naive population. And generally you get a slightly, actually, as I look at that, it doesn't look that different really across, but these are then small numbers across multiple doses. I mean, I think the interesting bar here probably is the green bar, which is all doses of gazelkamab, because that's got the largest number of patients in it, 100 patients. And then when you look at the green bars, you can see, if you compare bio-exposed to bio-naive, there is a bit of a drop-off of effect in the bio-exposed patients. And then if you compare the green to the purple, that's comparing ustekinumab to gazelkamab. I don't see the striking benefit that we saw in the sequence study here, but it is small numbers, I have to say.
I guess the only thing I'd say there, James, looking at clinical remission, looking at total gazelkamab versus placebo in the biologic, exposed and non-exposed, the delta's the same.
Yeah, they're nice deltas, yeah.
And it's not that you're getting better. Here, that delta there is 37, and the delta over on the right is 37 as well. So it's no great difference, I think it's fair to say.
And then following on from that, because of the nature of its treat-through design, patients continued on drug and could continue on whether they were responders or non-responders. So the new analysis that was shown at UEGW was looking at those patients who didn't meet the definition of non-response and at week 12, and therefore continued on drug. Did those patients subsequently get better? So these are patients who did not meet the criteria for response at week 12, so 0 responders at week 12, and then look to see whether ongoing gazelkamab in green or ustekinumab in purple or lilac made a difference. And what you can see is about 50% of people have a delayed response, and of course that's pretty much what Peter showed us with Mirikizumab.
Which is pretty much what every extended induction program shows.
Yeah.
About 50% of patients respond.
And if you then look at the end of the full year of treat through design, about a third of patients who did not respond to the initial 3 IV doses but continued with sub-Q dosing were in endoscopic response at the end of week 48. Again, pretty standard data. There's some a long-term extension study. We're now getting down to quite small numbers, and you see in patients who had benefited from drug over the course of the trial, there was persistence when you look over the course of the subsequent 2 years.
Is that the end of P19?
I think so. Oof,
I think it is.
Yes.
There's a couple of questions here that fit in quite nicely now. So the first is from Paul. How many P19 inhibitors do you need on your formulary?
Right, I think that's a great question. I mean, I guess it's going to come a bit down to cost, isn't it? Because clinically, I mean, what would on the data that I've seen so far, I would have mirikizumab for UC and risankizumab for Crohn's disease on my formulary if I had a choice.
But it's incredibly difficult to compare between
absolutely
studies. So you're right. I mean, if we were in a situation where one of the P19s, I don't think this will happen, was significantly cheaper than the others.
Yeah, that would be interesting.
That would be, a little bit like we see with JAK inhibition to an extent. And I want to bring in this other question here, which I've been holding back for a second, which says the EVOLVE trial shows that Vedo and Usti are similar in efficacy. Does the panel have any algorithm regarding usage of biologics, which one to use first and which one to use second line, etc.?
Well, I have to say, our practice remains that the vast majority is their first-line biologic and anti-TNF, infliximab for UC, infliximab or adalimumab for Crohn's disease. And the reason for that is that it's a fraction of the price of the other agents, and you have the flexibility of dose escalation, and you have the ability of the knowledge that that modifying the dose based upon drug levels improves outcome. Of course, what we then expect is the percentage of patients will drop off because of immunogenicity. I think what we're seeing, don't forget the EVOLVE trial, that was by a naive patient. So what we're seeing is that in an anti-TNF exposed patient with Crohn's disease at the current time, it should be risankizumab.
Yeah.
That's where the data takes us.
Yeah.
In the situation of ulcerative colitis, being honest, in an anti-TNF failing UC patient, it would be a JAK inhibitor for me.
Oh, interesting. There's a bit more subtlety to that, though, in relation to patient profiles and...
Yeah, there's a safety thing here. There's a lot more of a conversation. But if you want to look at the data, what drug is best in an anti-TNF failing patient in UC, I think it's probably a JAK inhibitor.
Yeah.
Or mirikizumab. Take that back. I've just said mirikizumab.
Right. Interesting. And then, of course, we'll come to S1P receptor modulators later. Right, we're going to go back to anti-TNF. I broadly agree with exactly what you say there, by the way. We're going to go back to anti-TNF and we're going to look at some subcutaneous data. Why are there more subcut trials coming out? Well, the answer to that is because the Americans like to have their own trials, basically. Oh gosh, lots more questions coming in. I'm going to hand that over to you. The Americans like to have their own trials, and so before subcutaneous anti-TNF got approved in the US, they needed to do some more controlled, placebo-controlled trials. And so we have Liberty trials, which is subcutaneous anti-TNF versus placebo in Crohn's and in ulcerative colitis. That allowed us to look at some more data in terms of whether you do better if you're on combination therapy with subcutaneous anti-TNF or whether you are on monotherapy, because there is some interest in this. So here's some sub-analysis of this, and here's some PK data. So what we know is that if you give subcutaneous anti-TNF therapy, then you have drug levels that stay at a higher level than if you give every 8 weekly intravenous infusions, which of course is is self-evident in my mind. What we don't know is whether there is a benefit to that, although to my mind, I would have guessed that the lack of low trough concentrations may give some benefit in terms of immunogenicity. One of the potential benefits, therefore, is you might not need combination therapy, or you might not get as much benefit from combination therapy with subcutaneous anti-TNF as you do with intravenous anti-TNF. And so here you can see some data regarding what actually happens to the drug levels, which presumably is most likely related to immunogenicity, although there might be another explanation for this as well, which we'll come back to. And you can see there is very little difference here between the solid line, that's monotherapy, and the combo line, that's combo therapy. But there is a slight difference there. I guess the only other thing that could drive that difference is if you accept that azathioprine actually has an effect in patients with inflammatory bowel disease, you may get slightly better disease activity. You may get slightly less leak of infliximab out of the tissue and into the bowel, so that may result in slightly higher drug levels. I think overall, though, this would tend to suggest to me that there isn't a massive difference in terms of PK between mono and combo, at least out to a year. We don't know beyond that as yet. And then if you look at the side effect profiles, again, you will see that there's not much difference here. A few more infections, but certainly no more serious infections in the combo arm than in the monotherapy arm. What we do see is a higher rate of anti-drug antibody positivity. Again, I think we have to just think a little bit carefully about this, because you can see the anti-drug antibody positivity rate is enormous here. 70% of patients in the monotherapy arm getting anti-drug antibodies, and that is decreased by the combo therapy arm, but with very little impact, it seems, on drug levels. And these are not the same as the kind of the anti-drug antibodies that we see that clear drug. Yeah. And I think it's not clear to me what this means. Yeah. That antibody positivity. Overall, I think the reality is that the benefit of combo therapy is probably going to be much less and perhaps not clinically significant with subcutaneous therapy.
Got a question here on that, and you might want to go back a slide, because I just want to make sure I've got. Yeah. There's a question here where the patients who had the subcut infliximab who then have lost response, were they able to go back to IV? And if they did they respond okay? That's the question here.
That's a good question. I think they dose escalated. They dose escalate, which we'll look at in a minute. I don't think there was a back to IV escape arm. I would have to double check.
I didn't think there was either.
And it doesn't say that. No. But we'll come to the dose escalation arm just here. So in fact, what happened is people who lost response. Oh, what happened there? There we go. People who lost response went on to subcutaneous. Went on to double dosing. So and you can see that here. This graph is not particularly helpful, I'm afraid. T1, T2, and T3 is tertiles of infliximab concentrations. I'm not sure that's the most useful analysis that we've got here. But I think what I can tell you, and again, this is combined data from both of the studies.
Yeah, you see at the top, Crohn's at the bottom.
Yeah, it shows that basically, if you dose escalate, then you recaptured response in a significant proportion of patients. So, of the dose escalated patients, 74% and 51% responded in the UC and the Crohn's arms respectively. So have I got that right?
Yeah, no, you got that wrong.
No, I have got that wrong, haven't I?
Yeah, because that's the time in which they dose escalate. The response is not as strong.
No, it's 25%. In ulcerative. colitis clinically and 53% in Crohn's disease, with lesser endoscopic responses there, and that's reflected there.
And that doesn't seem to show such a clear exposure response profile than we saw with the IV dosing, does it?
No, and maybe that's because in IV dosing you're much more likely to get PK loss of response, whereas here I guess you're more likely to be getting sort of immunological escape.
I think
loss
that's a
of
really
response.
good explanation, yeah.
And I wonder if that's what we're seeing here. And in fact, I don't think we show this, but there was also a network meta-analysis that included these data of subcutaneous infliximab and showed that that actually it performs pretty well in network meta-analysis. It may be better than IV. So
really interesting question here from Alenka. Did anyone decide to dose de-escalate patients in terms of reducing the frequency in those who had really high levels?
In trials, and certainly not in the clinical trials.
No.
What I don't know is whether any real world data is out there.
I think there's a study, and I think it came from Australia, but it was with adalimumab, dose de-escalating adalimumab based upon drug levels, and it didn't seem to show a drop-off effect, but everyone was very cautious because it seemed to be underpowered. I think that was at DDW this year.
Right, I'm not sure if there was definitely a Dutch study that did that, which actually I think it's published in the Lancet. So they looked at, or maybe Lancet GastroHep. I think it was in Lancet. Anyway, it doesn't matter. It was dose de-escalation. I can't remember if it was level driven. It must have been, or maybe it was just people in remission. And they showed that there wasn't much difference in outcome, but there was a little bit of worse outcome when you went out to 3 weekly. And then they sort of did an economic analysis of it. But of course, that economic analysis became really quite irrelevant because by that time, adalimumab had dropped to such a cheap price that there was no real incentive to drop from 3 weekly to 2 weekly.
So I think this is a study that answers a clinical question. It unfortunately was massively underpowered, and it was looking to see how you manage patients who are admitted with acute severe ulcerative colitis and who responded to IV steroids. So these are not the patients who are non-responders to IV steroids, who therefore go on to salvage infliximab or salvage cyclosporin. These are the patients who are responders to IV steroids. They meet the Travis or the Lichtiger criteria, and then you're going to continue their steroids, and then you're thinking about what maintenance strategy you want to put them on. And it randomized them, these steroid responding acute severe UC patients, to either having standard dose infliximab associated with a rapid wean of steroids, so they stop steroids within a week, and then combo therapy with azathioprine, or a prolonged course of oral steroids and azathioprine alone. And so effectively it's asking the question, if you come into hospital with acute severe ulcerative colitis, respond to steroids, can you get away with azathioprine, or should you all be putting these people onto infliximab and azathioprine combo therapy? This just effectively tells us that the patients were pretty sick. You can see high CRPs, low albumins, and what you see in the intention to treat analysis, and this is treatment failure. So treatment failure was absence of steroid-free clinical remission or endoscopic response at week 52. So it was ongoing active disease, requirement for a change of therapy, requirement for treatment interruption, colectomy, or death. So you were more likely to have treatment failure if you had just azathioprine monotherapy than if you had infliximab and azathioprine. This did reach statistical significance, although it would be fair to say that the power calculation was not reached. So this was an underpowered study. And I guess that's interesting because historically, if someone's responded to steroids, then all these patients were naive to both infliximab and azathioprine, by the way, before starting the trial. Sometimes we have let people go home on azathioprine, but this would suggest actually that was not a correct strategy, and that everyone should, if you've been sick enough to come in with proper acute severe ulcerative colitis, you should be there on infliximab after that.
Yeah, I'm trying to think why I would just use azathioprine nowadays.
In that population.
What's the advantage?
Yeah, in that population, I agree.
And can I just bring someone? There's a question here saying, do people still use adalimumab in ulcerative colitis?
I almost never do now.
Yeah, we do.
I think if people are on it and they're stable on it and they're doing well, I keep them on it. But I think if we're going to start an anti-TNF in ulcerative colitis, we start infliximab.
So we had been using it quite a lot simply because it's subcutaneous.
But now you've got subcutaneous infliximab,
yeah,
you see.
Yeah, there is still a bit of a cost argument there, though. So, I mean, it's not fair to say it doesn't work. And there are some very loud voices out there who say adalimumab does not work in ulcerative colitis. But it's simply not true.
No, there's phase 3 trial evidence for it that it does work. It's just that it doesn't. I mean, the phase 3 trial was just not quite as good with adalimumab, and then you had the dose-escalated adalimumab in UC Serene trial didn't seem to show benefit.
Didn't do that badly in Varsity.
No, but was good. But
and
and
in our cohort of patients, we get patients who respond, definitely, and stay well. It comes back to that question of, are you damaging a long-term outcome by using a drug where you have a reasonable, maybe a higher chance than with other drugs of not responding? Have you lost something by giving it a go?
Well, I guess
in ulcerative colitis.
I was going to say that all comes down to the fact, and of course, what you see in Crohn's disease, which is that early treatment, irrespective of drug, the outcomes are better. And there's a meta-analysis of clinical trials that shows in Crohn's disease, the shorter the disease duration at trial entry, the higher the response and remission rates. And the same meta-analysis is not true in ulcerative colitis.
No.
I.e., you probably don't have so much of a window of opportunity that you have to hit in ulcerative colitis.
I know, we're running short of time.
Yeah.
So let's go on to this study. It's another withdrawal study of anti-TNF. This is from the Spanish guys, the GETECU. They don't pronounce it like that. And basically, it looked at people who were in stable remission on combination therapy with infliximab or with adalimumab and with a thiopurine. I think it wasn't methotrexate. It doesn't really matter too much. And then they were randomized to either continue their anti-TNF or to stop their anti-TNF. And it was placebo-controlled, which I don't think has been done before, actually. The next thing to say about it is that these patients were supposedly in a more stable remission than, for instance, in Story or something like that.
Or Spare.
Or Spare, indeed. And they had to, and they all were on combination therapy, which wasn't true in all the studies either. It certainly was in Spare. Interestingly, they said they had to have no significant endoscopic lesions at baseline. I think you can probably say that's fair enough for an SCSCD of 5 or less. But you were allowed in with an endoscopic Mayo score of 2, and I wouldn't call that no significant endoscopic lesion at baseline. Either way, okay. 70 patients in each arm, and here's the outcome. And they said no difference between the two arms in sustained clinical remission at 12 months. You can see non-significant. Blue is the maintenance arm, red is the withdrawal arm. No difference in endoscopic lesions. Blue is maintenance, red is withdrawal. I'm not sure there is no difference.
You're beginning to see a little bit of a sign there. And when you look at Calpro.
And when you look at Calpro, indeed, there is a difference between the two arms. This is sold as there's no difference between continuation or not if the patients are in stable remission. To my mind, it's no longer a terribly relevant study. Because again, I'm not hugely keen to stop.
No, now that the price has come down
exactly.
So much.
So anyway, I think what they should be congratulated on is doing a massive placebo-controlled study here.
Yeah.
So they did really well. Sadly, it's a bit out of date.
I think, shall we skip through a couple because I think we're running out of time.
Yeah, go for it. We've got
so the TL1A inhibitors, I'm
minutes.
going to skip through because we went through that, the best of DDW. But it may be worth just talking a little bit about the JAK inhibitors.
So I think it's back to me. So that was cunning. You just missed out your section.
Yeah.
You flung it straight back at me. Maybe we won't do all of these because there's a lot of JAK to look at here. But let's start off with a bit of UPA. And this, of this, of course, is UPA in Crohn's disease. Induction studies, UXL, UXC, that's 45 milligrams of UPA for 12 weeks, and then re-randomized in maintenance to either placebo, 15 or 30. And here we see, actually, I think basically it's a larger cohort. I think they presented a sub-cohort
this is the larger cohort
previously. What do we take away from this? There's a lot of data on there. This is 30 better than 15? And the answer to that clearly here is yes, 30 is better than 15. And it's for that reason that if you were at DGW this year, you will have heard some very loud voices standing up on the podium and saying, you should always use 30, you should never use 15, which I know you and I discussed, and I don't agree with that.
No, I
don't. Because clearly 15 does work.
In some patients.
And there is the ability to dose flex. And I think we've got safety coming up next. Indeed, we have. And this is one of the reasons why I don't think you should throw the 15 dose out, because if you look, for example, at herpes zoster, it's a little bit higher in the 30 dose, so 7.3% versus 3.9%. And I think if we go on a little bit later, because we're now looking at, I'll show this data first. They'll come back to some safety data in a minute. This is patients who lose response. Okay, so these are patients who've been re-randomized after responding to induction. Okay, they've all had 12 weeks. They've all responded. They then get re-randomized to 30, 15, or withdrawal placebo. If they've gone into 15 or placebo and they relapse, they then go on to 30. So this is kind of asking the question, if you lose response, can you recapture? So
also, can you interrupt therapy?
And can you interrupt therapy? That's the placebo arm.
Yeah.
But, if we're making the argument, well, 15 is okay to try, you then want to know that if you go back up to 30,
Absolutely.
Are you going to recapture? And that's what these data show here. Specifically to that point, look at the right-hand side. These are the people who've relapsed on 15. And then if you look, for example, the hashed bars are at week 24 after 30 milligram rescue. The non-hashed blue bars are week 12. And if you look at response, 85, 90% of patients have recaptured response when you dose escalate them back up to 30. So I think it is worthwhile considering dose reduction.
Yeah, and certainly I would be confident that the lower doses are associated with lower risks of side effects.
And I'm just going to reiterate that here, for example, by showing serious infection. Look at the top here. This is looking at the long-term extension study. On the right-hand side, you see the UPA 30 patients, 4.6% of patients having serious infection, compared with 1.6 in the 15 arm. Sorry, no, it's not percentage. I beg your pardon. I think this is events per 100 years, isn't it?
It is, yes.
100 patient years. Either way, my point is that it's higher on the higher dose, and that's what you'd expect.
Yeah,
absolutely. There's a very clear dose response in terms of efficacy. There is a very clear dose response in terms of side effects. Reassuringly, if you just pop down to the bottom here, no major signals here really in terms of particularly MACE and VTE. So I think that's important as well. I think I'm not going to show any more in terms of the safety signals from the UPA trials, because I don't think it adds anything to those messages that we've given. Do you want to just briefly talk about filgo in Crohn's?
Yeah, I mean, this was the diversity trial, and it's really just to highlight the fact that upadacitinib is going to be the only JAK inhibitor that we have in Crohn's disease. This was a placebo-controlled trial, including groups of mixed bio-naive, bio-exposed, and purely bio-exposed, randomized placebo, one of two doses of filgo. We already know that 200 milligram is a more effective dose. Those that responded were re-randomized either to placebo or one of two doses of filgotinib. And what we see is that the induction study was very flat, both in the mixed population of bio-exposed and bio-naive. There was no significant benefit over placebo, and also in the pure bioexposed population. Perhaps you can see here that 200 milligram in a bioexposed population, when looking at a purely clinical outcome, did show significant benefit, but it doesn't really matter because the co-primary endpoints were not met, and filgotinib is not going forward as a treatment for Crohn's disease. Quick couple of questions here. Fiona asked if in the active trial, which was that infliximab in acute severe UC steroid responders, was it maintenance dosing or just 3 doses? It was maintenance dosing. They continued throughout the year of the study. It wasn't just 3 doses, then continue azathioprine. And then someone's asking about your opinion of JAK inhibitors in acute severe ulcerative colitis.
Yeah, we've done this in about 20 patients now. And the vast majority of them will be in one of 2 cohorts, either people who've previously failed infliximab and they come in and we use a JAK inhibitor to rescue, or the partial responders to infliximab rescue therapy where you know you're not going to win.
Yeah,
and of course the answer is it works.
It does
in
work,
a proportion of patients.
But I mean, it would be fair to say there are no controlled trials, and therefore we should be careful. I mean, it's not a replacement to infliximab in a bio-naive population.
No, totally agree. Okay, let's just talk a little bit about S1P receptor modulation. I just think this is an interesting area because this is a mechanism of action which is not being used much in the UK.
Yeah.
And I kind of don't understand why. This was some sub-analysis of the phase 3 studies, the True North study, and I'm going to just maybe I'll just summarise this. These data really are looking at a group of patients who I think are relevant in terms of the patients who I think are probably fit quite well with S1P receptor modulation. So it's a sub-analysis looking at patients who are TNF naive or advanced therapy naive, and then it's splitting them up by whether they have moderate or severe endoscopic inflammation during induction and during maintenance, basically. At baseline, and looking at their induction. This is induction here, and I think I'm just going to flip over to this slide here because I think this tells the story best. And over on the left-hand side, you've got those with moderate endoscopic disease. Over on the right-hand side, you've got those with more severe endoscopic disease. And basically, the separation with placebo is earlier in the patients with moderate disease, and it's possibly a bit better in patients with moderate disease.
Yeah, you're getting 80% there rather than...
Right. And I think, that it's almost something that is axiomatic, but equally, I think that's where this drug sits quite nicely.
So it's for effectively a 5-ASA refractory patient, is what we're saying. Isn't
Yes, it? As someone said at UEGW, OZA instead of AZA, and it's a nice little catchphrase. But it's a well-tolerated drug.
Yeah, I don't know if we're coming on to some of the safety data, but the safety data for ozanimod and the persistence data on ozanimod, we might go into that. It is really good, and certainly I've not found it a problem getting an ECG and starting a patient on a drug. I've just not found it a problem. Final thing to say is that the first 3 months of ozanimod are currently given free of charge. It's only if you continue beyond 3 months that there's a cost for the drug if it's delivered through your hospital pharmacy.
Right. What we have got is a whole load of etrasimod data, and I don't know if there's something you want to pick out here. Because we've done ozanimod, there is no safety data there. But whilst you're doing that, if you speak to the neurologists who've been using fingolimod and ozanimod for a long time, their sort of summary of this class of drug is that it's very well tolerated.
Yeah, I think it will be a slow burn. I think people will get more used to using it. I think its persistence as ozanimod is very attractive. Its safety profile is attractive, and it's going to be a slow pickup. And I think what it will have is quite established safety data, not only because it's been around now for longer than some of the JAK inhibitors, and we're getting the 4 or 5 year safety data for ozanimod being presented at DDW next year, but also because it's got that wealth of data for a much longer period of time in multiple sclerosis. I think the safety data is something that we really need to look at, and we need to follow and compare to the safety data of the other small molecules.
Nine years now for MS. Yeah.
So etrasimod is the next S1P modulator that we're going to see. It had 2 phase 3 studies. One was a treat-through design, induction for 12 weeks, maintenance for 40 weeks, and the other was a pure 12-week induction study, and then there's an open label extension study. I'm going to show you a couple of bits of data from this. This is the bio-naive population, and you can see the induction and maintenance data from the treat-through design and the induction data for the 12-week induction study. On the left, we have bio-naive. On the right, we have bio-exposed. I think this is telling us exactly what you just told us in the last slide, is that etrasimod is better in a bio-naive population. We don't have the cut for moderate disease versus severe disease, but these sort of deltas are both at induction with good maintenance in a treat-through design over time, I think is really reassuring. Same data you get for corticosteroid free, and I think that is reassuring. These are not a group of patients who need courses of steroids over time, and you can see here corticosteroid-free remission at week 52, and really quite impressive in the bio-naive population, perhaps a little less so in the bio-exposed population. I think one of the really interesting pieces of data that came out for me at UEGW was this, which is the speed of onset of etrasimod in patients with ulcerative colitis. And this is looking rather than weeks, which is what we showed you for some of the P19s. Again, this is looking at days, and you can see when you look at symptomatic response, you do start getting some benefit. So this is stool frequency and rectal bleeding. You get some benefit over placebo within 2 or 3 days. It's a little bit longer if you wait for symptomatic remission. And that slightly surprised me. I hadn't expected it to be quite so quick acting, but I think that was very reassuring. Yeah. And
might be a little bit quicker than ozanimod because there is no dose escalation phase with etrasimod.
Yep. And also, of course, the active moiety of etrasimod is slightly different from and the way that it's metabolized is different from ozanimod. When you look at rectal bleeding and stool frequency separated, you can see that the benefit comes in terms of stool frequency earlier rather than rectal bleeding, which may take a couple of weeks to resolve. This is a bit of a niche aspect of this trial design because they included patients who had isolated proctitis compared to patients who had more extensive disease. And the relevance of this is that the vast majority of trials exclude patients with limited proctitis because they're considered harder to treat. In the UC Elevate 12 and 52 studies, patients with proctitis were able to enter. And what you can see, the isolated proctitis placebo-controlled results are in grey and dark blue, and the standard left-sided extensive colitis patients are in lilac and light grey. And what you see is it works just as well in proctitis as it does in extensive disease. And I think that's reassuring, although I don't suppose that's game-changing from the perspective of use of drug, because we use all the drugs in people with isolated
We kind of do. And the other thing as well, it was a slight marketing type thing, I think. And instead of having to have 15 centimeters of disease, you had to have 10 centimeters of disease. Yeah. So, what's 5 centimeters between friends?
And how good are people at measuring 5 centimeters, 10, 15 centimeters at an index endoscopy? Anyhow,
but it's good to have data in proctitis, whatever.
I think we're drawing to the end here, which is probably a good thing because we're at time.
Okay, so let's very briefly look at obefazimod. This is basically a drug that increases production of a microRNA miR-124, which then has effects on macrophages and basically on the Th17 pathway, and that's where we'll leave its mechanism of action for the moment. And we have previously seen data from the induction program, which is sort of grayed out on the left here, which looked at 3 different doses of obefazimod for 8 weeks. For 16 weeks, but primary outcome was at 8 weeks. And then we saw here some open label extension data in this group of patients at moderate to severe ulcerative colitis, I should say. Just to remind you, yes, I think we've got the induction data here. And what we see here again at week 8 was that obefazimod was better than placebo across all these different doses, 25 up to 100, with no obvious dose response there. And then they went into this open label extension. I think we'll just whiz past those data there, because that's there, and onto the week 48 and week 96 outcomes here. And what you can see in terms of clinical response again is that people seem to be doing quite well if they stay on the drug. Overall, it's promising, but it's phase 2, it's long-term extension. This is now phase 3. Are you doing this study?
We're just starting the phase 3 study. Yeah. I think there's some important side effects just to mention.
Right, headaches is certainly one. I think there's some side effects coming up here. So COVID-19, I think we can probably not think about now, but headache is certainly something that was seen, and we've seen it in a clinical trial patient as well. Otherwise, nothing particularly to stand out there. Interestingly, just looking here, they say no headaches reported in the second year of treatment. I don't know whether that's because it stops being a side effect or the people with headaches have dropped out by the second year.
Yeah, a year worth of headaches would probably mean you continue on drug. We're just about to finish here, and there are a couple of last minute questions. I think this is a really important one. Zoster, if the patient develops shingles on upadacitinib, but they're well on upadacitinib, what do you do practically?
I would stop the upadacitinib for a while until they get better from the zoster.
Yeah, I mean, so first thing to say is...
Then I'd restart it.
Shingrix.
Right.
If you can get access to it, you can vaccinate your patients. It's safe, and it does reduce the risk of zoster. It doesn't eliminate it, but it reduces it.
Now available for patients 50 and over who are immunosuppressed. Yes. In other words, are IBD patients on treatment.
Yes. Other thing to say is in the clinical trial, they didn't actually interrupt the upadacitinib. In the vast majority of cases, they just treated through and the shingles just got better. We do treat with acyclovir if people develop shingles.
But you stop?
Honest answer is I probably do stop at the moment. Yeah. I don't have enough experience to say not to. I do stop for 2 or 3 days until the lesions have started to cross over. Yeah. But I do give acyclovir.
Yeah.
I think there was one question here. Can you give Shingrix in varicella Ig negative individuals who have never seroconverted? That is a good question to which I don't know the answer.
No, I don't know the answer to that either.
I think would you not just give them standard varicella vaccination? But that's a live.
It's live, isn't it? Yeah.
I actually don't know the answer to that question. I will look it up and come back to you.
Very good question.
Yeah. Sandia asked here, if you can't get hold of risankizumab, so I expect we're thinking about a paediatric population, we must be thinking about Crohn's disease. Would we be keener to use upadacitinib or ustekinumab? Oh, and it's a patient with extensive small bowel disease. Ugh. That's a really challenging question. Yeah. I've used upadacitinib in that situation with some benefit. So for me, I think if
and it's I've used ustekinumab.
Yeah, if it's an anti-TNF failing patient,
it's a really tough one. I think it's certainly in an adult population, you're more likely to have other factors that are driving that decision-making process there, like comorbidity. So at the moment, cost-wise, Upa is cheaper. Significantly, I think, than ustekinumab.
Yeah.
But I don't have a strong answer there.
And so we're going to finish here. We'd like to thank you very much indeed for joining us and for spending some time with us running through the data. It would be hugely helpful if you could complete the evaluation form. It's there for you to complete now, and it will be being sent out. It's really helpful for us to get this feedback. It's what we can use to get sponsorship for these kind of meetings if you think they're useful and something that we should be considering doing in the future. And with that,
One last point, you can download the slides is the other thing to say. They're available as well. But we must say thank you to our sponsors, BMS, Celtrion, Lilly and Takeda, who have very generously supported this. We're hugely grateful. And as James said, please do provide feedback to enable us to make it as good as possible in the future and hopefully to continue it.
And just to finish, Stuart, thank you so much. Stuart Hill, I'm pretty sure as a pharmacist, thank you so much for that. The answer is yes, you can give Shingrix if you're varicella IgG negative. GPs are already doing it.
Really good point.
Stuart also did a cost comparison of ustekinumab versus risankizumab, showing that ustekinumab was cheaper. But Stuart, I think that might be in 12-weekly ustekinumab rather than 8-weekly ustekinumab. But I take your point very well. Thank you very much indeed. And thank you to everyone.
Good night.
That is the last slide. Good night.